all through the day, and it's been a wonderful session that you have organized, right from the lectures and the operative demonstration, the stroboscopy, and the wonderful quiz that your PG students participated in. Okay, so my and should I go ahead with the presentation? Hello?
Yes, ma'am.
Yes, yes, please. One of you can keep yourself unmuted so that I can get some feedback. Okay?
Sure, ma'am. Sure, ma'am.
Yes, yes, yes. Okay, so I'm Dr. Anagha Joshi. I'm a professor at Sion Hospital, which is Lokmanya Tilak Hospital, and a consultant at Exchange Reliance Hospital. So today I'll be speaking on glottic insufficiency. Now let us see what is glottic insufficiency. So it's basically the inappropriate escape of air during phonation due to the incomplete closure of the glottis. 1 minute, I'll just reduce my window. Okay. So the patient typically has dysphonia and aspiration. So what are the causes? It could be vocal fold immobility due to either vocal cord paralysis or vocal fold paresis or cricoarytenoid joint fixation. So you're hearing that sound? The patient's voice, did you hear that?
Yes, ma'am.
Yes, perfect. Okay. So patient has a very breathy voice, may present with aspiration, has vocal fatigue on the prolonged speaking, sometimes complete aphonia as this patient had. The other reasons could be vocal fold atrophy or soft tissue deficiency, either again due to denervation, which can cause atrophy of the vocal folds, or age-related changes such as in presbylarynges that we can see in this rigid laryngoscopic video, and tissue loss because of ablative surgeries or destructive vocal fold procedures, vocal fold scars, sulcus vocalis deformity, as is seen on this video, where there is you can see bilateral sulcus with a glottic gap. The patient, apart from having a breathy voice, the voice is very rough.
भोपाल गणेश विकास मंडल टाटा पावर लाइन सुशील नगर एमजी रोड धारावी मुंबई 70.
It is not only breathy, but it's very rough. So this is typically seen in sulcus vocalis. So what are the treatment options which are available to us? You can give voice therapy, surgery in the form of either temporary buccal fold injection or permanent procedures like again buccal fold injection with different materials or laryngeal framework surgery or surgical treatment for sulcus. Now, traditionally, we have been following the norm of wait and watch policy. Now, what is that? Wait a watchful expectancy for the vocal fold for the phonation to return or for the other vocal fold to compensate. This is typically what we do in unilateral vocal fold paralysis, which, yes, to a certain extent, it is true. And the patient has a very breathy voice. He was a patient of pulmonary Cox with left vocal cord paralysis. And after a period of 6 months, we had a complete recovery of his voice. So this has been followed traditionally. And if there was no improvement, then we would go ahead for laryngeal framework surgery or some permanent injection augmentation. But this has been replaced by early temporary medialization. Now, what happens when you do have a watchful expectancy that you wait for that period of 6 months? What happens during that period? Patient has persistent hoarseness, persistent aspiration, he has inability to work, especially in voice professionals, and persistent difficulty in communication. Uh, Reinnervation does not restore the useful movement of the vocal folds because of the synkinesis, that is a non-selective innervation of adductor and abductor muscles. So what happens is that the muscles that perform the opposite functions contract simultaneously, resulting in the immobility of the vocal fold or hypermobility. So even if there is re-innervation, there is synkinesis. So there is no effective movement of the vocal folds. Also during the wait, sometimes you can get a good compensation, but very often you get a very supraglottic hyperfunction You can get vocal fold granulomas because of the hyperfunction, or you can have a vocal fold atrophy due to long-standing innervation. What are the advantages of the early medialization? So it gives you immediate reduction in the aspiration, improved ability to cough and communicate, especially in voice professionals. What generally happens when there is a vocal fold paralysis, there is instability of the arytenoid. So the arytenoid tends to sag down along the cricoid because of the lack of the muscle control over that. So early medialization will stabilize the arytenoid and allows for a better resting position once the synkinetic reinnervation is complete. And the paralyzed vocal fold is medialized, and there is a vibrotactile stimulation from the contact of the contralateral mobile vocal fold. So, what is the course of action in cases of unilateral vocal fold paralysis? So, if the patient presents early and has aspiration, desires a better voice, or is a voice professional, you would go in for temporary immediate injection laryngoplasty. But if there is no aspiration, there is no dysphonia, patient does not, or if the patient does not desire, refuses for early medialization, you can continue with the voice therapy for 3 months. Or if the patient presents late to you, say like after 6 months to a year after the onset of paralysis, or after optimum speech therapy, or after temporary medialization, if there is uh, again hoarseness or return back to the hoarse voice, then you can do type 1 thyroplasty with or without arytenoid rotation. So, what would be the ideal material for vocal fold injection? It has to be biocompatible, easily injectable, or removable easily, readily available with minimum preparation of time, and biomechanically it has to be similar to the vocal folds and resists reabsorption and migration. There are a variety of vocal fold augmentation materials used. Most of them either are so temporary, like gel foam, they just last for a month. The other products Zyplus or Symetra, Radius Voice Gel, and collagen-based products are not available with us. So hyaluronic acid gel, that is in the form of Restylane or Hyloform, is readily available, and this is the material of choice what I use. And for permanent medialization or a longer lasting medialization, autologous fat would be the best option because Teflon is, as you know, is not to be used as it causes granuloma, and the calcium hydroxylapatite is not available to us. Uh, Hyaluronic acid has excellent biocompatibility and there is no inflammatory reaction and is closest matched to the native vocal fold viscoelasticity. So, how will you augment? That is, the injection has to be given at a point uh, just lateral, uh, where the transverse line from the tip of the vocal process. So that this is the tip of the vocal process, which meets the superior arcuate line. So at the just lateral and anterior to this junction, you have to inject. And the second point of injection would be at the mid-membranous region. The the depth of injection should be 3 to 5 millimeter, and uh, injection into the rinky space, that is the superficial lamina propria, has to be avoided, and a certain amount of over injection is recommended as some amount of it could be resorbed. So what is the technique? You need to first give topical anesthesia in the form of laryngeal gargle, that is patient through a curved the cannula. You have to drip 4% lignocaine while the patient is phonating. So that anesthetizes the larynx. Or you can also inject into the cricotracheal membrane and ask the patient to cough. So that also anesthetizes the larynx. So this is how the position of the inject. That's me. That is this. I am injecting transthyroid by the transthyroid technique, and that's my assistant who is holding the flexible laryngoscope, and there's one more assistant who is stabilizing the patient's head. So the patient is in a sitting position, and uh, the the TV trolley and the monitor is behind the patient. So this is, I'm just showing injection through the thyroid technique, through the transthyroid membrane. So this is the skin marking. That's the thyroid notch, and this just above the thyroid notch, you would inject. Uh, this is the point of insertion of the needle. So the needle, 1.5 inch needle, 25 gauge needle is bent at two sides, one at 45 degrees at the hub, and again at 45 degrees around 1 to 1.5 centimeters from the tip of the needle. So the final needle is perpendicular to the syringe. So the needle will emerge through the petiole of the epiglottis. And with this technique, you can inject bilaterally also. So it's very convenient. So here you are injecting just lateral to the superior articulate line and just anterior to the vocal process at a depth of 3.3 to 5 millimeters. And once you start injecting, you will see that the vocal fold has started pumping up. Sorry. Okay. You can check the patient while phonating, and you can optimize the amount of injection that is to be given. So typically, if for a smaller phonatory gap, around 1 cc is enough. But for larger phonatory gaps, you need to give 2 cc of the solution. So that this is the rigid laryngoscopic video of the patient before injection, and that is after injection.
शकुंतला जैन 6 महीने का तकलीफ है 1 2 3 4 5 6 7 8 9 10
This is the
11 12
patient's
13
voice operatively.
मेरा नाम शकुंतला है 1 2 3 4 5 6 7 8 9 10 11 12 13 14
There
15
is
16 17
immediate restoration of voice, there is improvement in the maximum phonatory time. And you can see that there was preoperatively the patient had a high pitched sound. And that is typically seen in vocal fold paralysis. The patient has a high pitched sound, and that is also corrected with the injection. Other approaches can be transthyroid. This is what I do nowadays with the onset of COVID. It is much easier. There is no exposure of the needle inside the larynx. And in younger patients, it is very comfortable and very easy. Can be cricothyroid or transoral, or sometimes if the patient is not cooperative, then you can give a trans microlaryngoscopic injection that is under general anesthesia. Injection laryngoplasty is cost effective, minimally invasive, performed transorally or can be performed transorally and in the as an office procedure, done under local anesthesia, and you can re-inject again if there is reabsorption of the injection material. As I said, if the patient has a reversal of the hoarseness or patient presents to you late, 6 months to 12 months after the injury, then you can do a permanent medialization in the form of thyroplasty, where you create a window in the thyroid cartilage and insert a silastic implant inside to medialize the vocal folds. So typically the window size is 5 millimeter to 8 to 10 millimeter in females, and for males it is 6 millimeter to 12 millimeters. The window is placed 5 millimeter posterior to the from the midline in case of females, and 6 to 7 millimeters from the midline in case of males. And there has to be at least 3 millimeter distance from the lower margin of the thyroid cartilage. So this is also done under local anesthesia. Infiltration is done, increased incision is taken at the level of the lower border of the thyroid cartilage, and the window is marked. Now, this case was a elderly gentleman, so I had to drill the cartilage to remove the because it has ossified. And then you check for the amount of medialization which is required by assessing the patient's voice. This is a silastic block which needs to be trimmed. So the amount of medialization required is judged, and the silastic block is carved and trimmed accordingly. So this you judge what is the amount of anterior medialization which is required, and the posterior medialization, and the silastic block is inserted. You check by doing a fiber optic laryngoscopy. Uh, so this was the patient's preoperative visual laryngoscopic video. This is the post-operative video. So the while inserting the block, you have to be careful that the medialization has to happen at the level of the true cords and not at the level of the false cords. This is the patient's voice. This is
एक लांब श्वास घ्या आणि आ असा म्हणा.
so it's thyroplasty can also may require auditory induction if there is a larger posterior glottic gap. So this is so that the vocal process rotates more medially so as to close the posterior glottic gap. Now, this was regards patients with vocal hold paralysis. Now, what do we do with patients with sulcus vocalis or scarring or pressed diaphonia? Uh, they have bilateral lesion. There is no chance of spontaneous recovery, so they need some permanent treatment. There is loss of in sulcus and scarring. There is loss of the superficial lamina propria with phonatory gap, and you have to reconstruct the SLP along with medialization. So what are the options that we have? We can augment with fat, that is fill up that gap with fat, or inject fat, so or medialize the vocal folds with fat, or with some permanent medialization material, or do a surgery for the sulcus, which is Pontes or modified Pontes. So what are the different so for basically fat, you need to first harvest that fat, and there are different techniques for uh, fat harvesting. Either you can remove it as a monoblock. This is used when the fat as a block is to be inserted into that sulcus pocket, or you can do liposuction and aspirate the fat and then process it further by centrifugation, or you can remove a block of fat and then dice it and mince it into small pieces and uh, fill up the syringe with for injection. So this is why liposuction, where you take the fat, liposuction, and then centrifuge it and then fill up the syringes with the fat. Fat is injected. It's a similar technique. It's only that the fat injection cannot be done under local anesthesia. One, because you need to use a thicker needle for that, and to harvest the fat, patient needs to be under general anesthesia. So, but the technique of injection into the vocal fold is similar. So, you insert the needle just lateral to the vocal fold, that is the superior arcuate line, and let the uh, vocal fold medialize it, get medialized. The difference between is that you really need to overcorrect very much, more than 50% of overcorrection. There's over injection is required with fat because there is a high likelihood that the fat will get resolved. So there is a common question as to why we don't use fat for temporary medialization. One is because although it gets reabsorbed, whatever some amount of which of the fat which doesn't get reabsorbed stays permanently. Okay, and only thing is that we cannot predict how much of it will get reabsorbed. So you have to inject so much so that the vocal fold gets medialized right till the midline. Then the second option that you have for sulcus is that you can do fat implantation. Now, what is fat implantation? This is a little tedious procedure. You have to first take an incision, that is, do an epithelial cordotomy, that is, after infiltration, subepithelial infiltration. Uh, I hope all of you can appreciate the sulcus, which is there bilaterally. So once you take a epithelial cordotomy incision, the sulcus is elevated off from its insertion, either if it is inserted into the vocal ligament or it's inserted stuck to the muscle, underlying muscle. And you create a pocket, and into that pocket, you insert fat. Once you have inserted fat, that epithelial cordotomy incision has to be sutured with 60 Vicryl. Now, this is the most difficult of the procedure where it's difficult to take sutures inside the larynx. So apart from the fat implantation, I have you can see that I'm also injecting fat laterally to medialize the vocal fold. So in this procedure, you're creating superficial lamina pro, recreating the SLP as well as medializing the vocal fold. So the drawback of this procedure is that it takes a very long time for this vocal fold to heal. So this is
दीपाली शिवाजी परंडा जुतारा रोड शिवाजी नगर नंबर 2 गणेश सोसाइटी मुंबई पश्चिम.
this is the patient's voice preoperatively. Just a little disclaimer is that you have to uh, uh, counsel the patient that the voice will not be absolutely normal. In sulcus, it's really difficult to recreate the entire superficial lamina propria. So there has to be a very guarded prognosis when you're operating on a sulcus patient. So if there is very minimal hoarseness, don't take up the patient for surgery. This is the patient's post-operative voice.
माझे नाव दीपाली शिवाजी परंडा. माझं ऑपरेशन 10 जानेवारी सायन्स हॉस्पिटलमध्ये झालं.
Which is
1 2 3 4 5 6.
we got a very satisfactory result with fat implantation as against fat injection, because we have found that the fat injection causes it gets absorbed when the patient's voice comes back to the original state. So there was improvement in the voice analysis also, as you can see here. The advantage of fat is that has excellent biocompatibility. It's inexpensive, as you know. The ample amount of is found with every patient. It is similar in viscosity to the lamina propria, does not disturb the vocal fold vibration, even if it is injected into the superficial lamina propria. But the disadvantage is that it decreases in volume in the early postoperative period, and the degree of post resorption differs, and it depends upon the condition of the fat which is injected and requires a long time for harvesting. As I said, there's a risk of reabsorption and needs a skin incision for the fat harvesting and general anesthesia. So now there's again here nowadays we have sort of revisited the earlier principle or technique which was suggested by Ponte. There is a slicing mucosa technique which I do for the sulcus is where you are cutting the tension lines to or the scar tissue so as to yield a free mucosal vibration. So the principle is that you interrupt the fibrotic or tension lines, and where you take, so this was actually not the ideal case because the sulcus was going right till the muscle that I think during a discussion there was a discussion on sulcus vocalis. So this is sort of a type 2B where it's going right till the level of the muscle. So you take a cordotomy, raise the sulcus, and once you have raised the sulcus, so that is freed from its attachment underneath. Then you take horizontal or perpendicular incisions so as to break the scar tissue or the tension lines. And you also have also injected fat laterally. So what has happened now, there is a raw area now, but what will happen is that there will be re-epithelialization over the raw area, which will help in sort of, if we have seen that the yielding a free mucosal vibration. Now there is a modified technique as suggested by Dr. Nupur, that is a laser assisted sulcus release, where instead of cutting with cold instruments, you take laser cuts horizontally. Now, this particular technique does not require a lateral cordotomy incision, and you need not elevate the epithelium from its bed. So, you just take horizontal incisions, and this does the same job as the with the cold techniques. So this was the patient's preoperative voice.
1 2 3 4 5 6 7 8 9
Very hoarse
1
voice.
2 3 4
And this was after the.
मेरा नाम अमनी सिंह है। मैं विरार की रहने वाली हूँ। मैं एक हाउसवाइफ हूँ। मेरा
Unfortunately, couldn't get the laser surgeries, but this was the just with the cold instruments. Although at the end of the surgery, it looks very ghastly, as even I thought what I had done to this patient, but I was pleasantly surprised with the patient's voice post-operatively. And this is the post-operative strobe of the patient. You can see that the mucosal wave has returned. Can you see that?
मेरा नाम अमनी सिंह
This was again the sulcus vocalis, again with the slicing technique that was done. You can see the mucosal wave coming back to normal.
मेरा यादव है। मैं मानपुर की रहने वाली हूँ। मानपुर मंडला। मेरा नाम सुनीता यादव है। मैं मानपुर की रहने वाली हूँ। 1 2 3 4 5 मेरा नाम सुनीता यादव है। मेरा नाम सुनीता यादव है। मैं मानपुर की रहने वाली हूँ।
Okay, so sometimes you have seen that the laryngoscopic video, you can see a very innocuous little polyp here, you can see. The patient's voice is really very bad. I mean, you are wondering what is wrong with the patient, and this is the time when the stroboscopy is very, very essential. So you can see that the mucosal wave is completely absent at this particular region. So there is a lot of scarring, and this is how you would. This very, very important. The stroboscopy is very important when you want to give a prognosis to the patient regarding the surgery. So there, here you can see that there is loss of the lamina propria, due to which the mucosal wave is absent, and which causes severe dysphonia. This was
भोपाल गणेश विकास मंडल टाटा
And what in such cases, what we do is that we inject subepithelial, I mean, steroid into the subepithelial uh, layer. So that has given excellent results. But nothing else works.
My name is Gopal. My address Sri Ganesh Vikas Mandal, Tata Power Line, Social Nagar, MG Road, Dharai, Mumbai 17.
That was how we found. This was very hoarse voice with very grade 3 dysphonia. Very found a reasonable voice in this patient. So to conclude, the take-home message is early medialization immediately corrects the patient's vocal as well as aspiration problems, while still allowing for the spontaneous recovery to happen. Injection laryngoplasty is a minimally invasive procedure and can be carried out as an OPD procedure as well. And hyaluronic acid is a preferred material for temporary medialization with its very good properties. And type 1 thyroplasty with the silastic block is least expensive, precise. It can give precise medialization and is longer lasting in cases of when you need permanent medialization. Also, fat is excellent as a graft material for permanent injection. 30 to 40% will get ears out, and hence you need to overcorrect. Hello, sorry. Excuse me, I think you're not mute. Yeah, and treatment of sulcus involves augmentation or fat injection as well as excision of the sulcus with the slicing technique. So thank you very much. And I would really like to thank the organizers for this workshop for inviting me to take this lecture. And thank you very much and wish you all the best.
Anagha, it was so mesmerizing for the audience, all pasted, no one taking a lid down. So I think you need an invitation for Jabalpur.